Hi, thank you. Welcome everyone to day 2, track 7. My name is Sonu. I am a master's student here at the Michigan School of Public Health. I'm looking forward to hearing your presentations.
So welcome everyone, and I'm really looking forward to this discussion on how to build resilience to the workforce. And as we saw in the plenary discussion earlier, there are so many challenges that COVID has presented, and this notion of strengthening the public health supply chains, not just in the context of the COVID era, but going forward, I think is very important. And I'm sort of very excited to hear your experiences and your learnings and your takeaways from what's happened in the last few years. So we have three talks, and I would like to start with the talk from Village Reach. It's on supply chain resilience for public health. Is it attainable or a fallacy? And seems like a very interesting title. So with that, I would hand it over to you, Maradzire, Petrosky, and Jenny. I hope I pronounced your names correctly. So you have roughly about 20 minutes. Thank you.
We have submitted a recording, so I'll go and share that now.
Good morning, good afternoon, everybody. Welcome to this presentation entitled Supply Chain Resilience for Public Health Systems in Low-Income Countries, Attainable or Fallacy. My name is Pudzai Magadzire. I'm a Senior Technical Advisor at Village Reach, and together with my colleagues, Sierra Petrosky and Innocent Mainjeni, we're going to orient you on a framework that our team has developed over the last 5 months. Specifically, we will provide you with some background and rationale for this work. We will inform you about our key objectives and take you through a deep dive into the framework itself. And finally, a snapshot of its application to date and as foreseen in future. Now, what problem are we seeking to solve? Resilient, high-performing, and agile supply chains form the basis of strong primary healthcare systems. In the last 2 years, the world has experienced the impact of supply chain disruptions on availability of essential commodities. Yet, low-income countries have to create new strategies and models for each unforeseen disruption. For example, currently with COVID-19 and what has happened with the Ebola response, with the cyclones, and many other disasters that have happened in the past. This creates time lags and requires starting from scratch each time. And many of the existing supply chain solutions cannot be easily adapted for a response. Another issue is that outside players, for example, UN agencies, have the capacity to respond urgently, but they may respond and then they leave. And they may not be working closely and as part of the national government response. So the responses are fragmented and not sustainable. Another issue is that while countries may have SOPs for emergency, it's important to know that what they enable and what they don't enable. For example, procurement processes. Are those SOPs able to enable quick and efficient procurement of commodities as required? Is the country able to unlock funds promptly when there is a crisis? Now I'll take you through some of the key objectives that we have for this work. The first one is, we're intending to develop a shareable health supply chain resilience framework built on global experiences and tested in some of the core countries that we work in, Mozambique and DRC. We want to illustrate the importance of readiness, response and recovery, and examine relationships among key actors in public and private and technical assistance providers. And finally, we want to collaborate and advocate for government partners and donors to develop and adopt a common framework for any response based on a foundational set of principles. I'm going to take you through the timeline that we are applying to this work. So Village Reach has been strengthening supply chain performance for over 20 years in sub-Saharan Africa. And so as part of this process, we started by reflecting on our experience in the different countries. And then we combined that with an extensive literature review of gray and published literature involving both literature in both French and English. And as a third step, we are now validating our results and our framework with partners and governments. We intend to complete this process by December 2021. And our presentation right here at this conference is part of that process of validation. And so we're hoping that today you will find the session helpful and that you can at least provide us with some feedback on the framework that we've created thus far. I'll hand over to my colleague Sierra, who will take us through the deep dive into the framework.
Okay, thanks, Vijay. So here is our most current version of the Health Supply Chain Resilience Framework, and I'll start by just orienting you to the overall structure of the framework. We chose to look at resilience in 3 stages, the first being a pre-disruption stage. So this is when it's life is normal, things are calm, your supply chain is running as it normally does. The second stage is during disruption. So that is when something goes wrong. It could be any number of things, but it causes a disruption to the system and quick responses are needed. The third stage is the post-disruption stage. This is when we're recovering, we're going back to life as normal or a new version of normal. And we want to use the lessons that we learned throughout the disruption to inform a new way of doing things. And we've structured this as a cyclical process. So after you start to implement those lessons learned, you move back to a new pre-disruption phase. We've also included a couple of cross-cutting elements at the bottom here. So these are things that we believe need to be working really, really well throughout this whole process during any given stage. So each of these might be more critical or more pronounced at certain times, but you need to make sure that they're being addressed throughout. And since we have a limited amount of time, I won't do a deep dive into every single piece of this, but I'll pick out a few from each stage. So starting over here in the pre-disruption area, we have the need to pre-position a network of players. And so our main thought here was that once you're in a disruption, there's no time to be making new relationships. There's no time to be identifying new players. You need to already have organizations and people in place who have the capacity and know their capabilities and can ramp up quickly to respond. So these people would ideally include government at the helm alongside private sector, social sector, maybe academia, etc. So it should be a really organized and well-coordinated set of players. It might look different in different places, which is totally fine, but it's one of the most important pieces to put in place immediately. And right below that, we have to pre-design core response functions. So that's making sure that those people that you have in place also have clear roles and responsibilities, a job description based on their capabilities and resources so that they're able to ramp up very quickly. Another layer right below that on the pre-disruption phase is the need for an emergency strategy and preparedness plan. So this is something that should be in place as much as possible before something happens. It's difficult to create one of those that's broad enough and specific enough. But especially from a government perspective, you need to make sure to have something in place that's clear about what organization or what department takes the lead, depending on what's going on. So moving over to phase 2, the during disruption phase, one of the things that we made sure to highlight was the need for effective and clear communication and coordination lines. So it's really difficult to communicate and coordinate departments and organizations and resources at scale all of the time. It's a difficult thing to do. But during a disruption, any gaps that exist there are further amplified. And this is a piece of this framework that came through very, very clearly during our literature review and during all of the interviews that we did with experts in this sector. So it's one that we're definitely looking a lot into applicable solutions that we can package alongside this framework to be able to provide to people as a sort of menu of options of approaches and tools that can be used during a disruption. Right below that, we've highlighted an importance of looking for opportunities to leverage appropriate innovations. Disruption isn't necessarily the right time to be piloting new innovations, but if you have previously piloted something that had promise, or there's some evidence-based pieces that you can utilize to do things differently, we really, really encourage that. So innovation to us just means doing things in a different way. So utilizing new ways of effectively and efficiently delivering to consumers in a data-driven and lean way during a disruption. Moving over to the post-disruption phase. So this phase, we focused on utilizing the lessons learned in a disruption to improve the supply chain. So after the disruption, certain aspects of the supply chain should be reconfigured so that it functions at least as good, preferably better than it did prior to the disruption. And then again, down at the bottom, we have these cross-cutting elements. So we've included 3 that we think are important to be implemented across stages. So the first is data visibility. So collecting and collating data and sharing it, or at the very least, making it available to stakeholders all of the time. Leadership is extremely important, and that one especially might look different at each stage. Different people might be tapped in to do different things, but it's really important to have experienced, appropriate, recognized, and well-supported leaders at the helm or ready to tap in. And then we have a public engagement piece. So making sure that citizens are informed at all times, and ideally that they're actually actively participating in policy development and in response. And then rather than having this be a standalone framework like this, which we think works okay, we did want to add some elements that indicate how you can move through the phases and how different specific pieces of this are interconnected. And a way that we're trying to do that is, for example, showing that you perhaps pre-positioned a network of players, you created their core functions during the pre-disruption phase when things were calm. Now something has happened and it's time to activate those, and you have to go back to what you described before, ensure those are in place, and then activate them. Another example that we have in here is that you should have designed an emergency strategy and preparedness plan during the pre-disruption phase. Now something has happened, you should go back to that strategy and implement the communication strategies that you had in there, the coordination lines, make sure that you're following those plans that you made sure to lay out. And then the final one that we've done so far is utilizing things like all of the data that you collected pre-disruption or during disruption, and using that data to inform decisions going forward. Also using that network of players that you activated, those professionals that have been here throughout the disruption, have learned a lot, and taking their lessons learned to make sure that you can build the system back better after something has happened. So this is where we're at with the framework so far, and we would welcome any feedback from you after the session. And for now, I'll go ahead and hand off to my colleague, Innocent.
Thank you, Sierra. So having learned about the work we have done thus far, I have some great news for all of you. So at Village Reach, we strongly believe in radical collaboration. Thus, we are actually cognizant of the fact that you all have had valuable experiences around steering your supply chains in various tides of disruption. We would therefore like to graciously invite you to feel free to contact us and provide inputs from your respective experiences which would not only add great value to this particular work, but it will also actually make sure that it actually brings the much needed input that will make it more applicable to most settings. We will be involved in further consultations and deliberations with diverse stakeholders to further refine and enrich this particular supply chain resilience framework within the next few weeks up to the end of December or potentially to early January. Furthermore, I just wanted to let you know that as Village Reach, we have actually several examples around how this particular approach that has just been presented to you moments ago has been pivotal to the work that we do. For instance, in Malawi, under a national Drones for Health progressive scale-up program that we are involved in currently, the initial steps involved streamlining key roles in drones for health work. So among the key players that were prepositioned in this particular work were the Ministry of Health, which provides strategic leadership for the program to ensure it aligns with the national priorities. The local Department of Civil Aviation, which provides the mechanisms for setting aviation standards, as well as flight approvals locally. But also as Village Reach, we provide supply chain technical support, as well as guidance on activity implementation. And we also have Swoop Aero, an Australian drone manufacturer, which provides the technical expertise and architecture for drone flights, and also the local district council, which are actually providing the much needed human capital, which is able to facilitate the drone network movements. This is all made possible with financial contributions from several private sector players, as well as other philanthropies. It is therefore no surprise to see that from May to October 2021 alone, we've been able to use this particular drone delivery network to actually be able to supply over 9,000 routine vaccine doses that is actually on demand, over 7,000 COVID vaccine doses, over 1,700 TB and HIV samples, and over 100 other types of products have actually been moved in total. And this has led to serving over 14,000 people in hard-to-reach communities in Malawi. This has happened right in the midst of COVID by leapfrogging the challenges that come with traditional means of transportation. This is more so the reason why we look forward to interacting with you on this exciting framework, so that we are able to actually put into perspective your experiences on this particular work. We are very thankful that you were able to join us for this particular presentation, and we look forward to your feedback in the next couple of weeks. Thank you.
So thank you very much for this very interesting talk, and I found a couple of things very inspiring. And before I ask you my set of questions, we have about 5 to 10 minutes. I would like to open the floor up and see if there's anyone who has any questions for our speakers. Yes, Pamela, please go ahead.
Thank you very much, Village Reach team, for that exciting framework. I think my question would be to do with the fact that I'm hoping that this has been developed at the back of the emergency, and that there's also the humanitarian logistics group with their medical supply chain, which is often used during emergency or focuses on emergency. How much collaboration, coordination, or alignment or contribution have the humanitarian logistics sector made, so that we do not duplicate activities or create additional good tools that could only end up bogging down the implementers, particularly during an emergency situation. Just checking on how much collaboration has there been with the Humanitarian Logistics Association group for their input in something that is so important like this. Thank you.
Thank you very much, Pamela. Convener, would you prefer that we answer question by question?
Yes, please.
Sure. Thank you very much, Pamela, for bringing that very important point. The process that we have taken up to this point is to review what has been available in the public domain. The group that you mentioned is not one that we have specifically consulted with, but we will certainly take note and review what they have. One of the things to note about the framework is that at this stage, we have identified the major components or elements of the framework, but under each one of those elements, we are wanting to catalog a set of tools that have been developed even by other players. So for example, if the organization or the group that you're talking about, for example, has tools that could help under, say, assessing and addressing vulnerabilities and capabilities, in the next phase of the work, we would look at what they have, catalog what they have, and actually reference that this is coming from that group. And we will do a similar exercise for each of these elements, for that very same reason that you have mentioned, that we do understand that there are other players who have done some good work around this area, and we definitely do not want to reinvent the wheel. So we'll be open to looking at what tools exist from different organizations and putting them together so that governments and their partners can also have good visibility of what is available, and they can choose what it is that they would find helpful. Over.
Thank you. Thank you so much for that response. We have got one couple of minutes more. Is there anyone else who has any other questions? I have a quick question for you, and it builds on, I guess, Pamela's point, and that is, is there something different about the COVID-19 experience than the humanitarian logistics and other crises? And the reason I ask this question is, you have this framework, and a lot of it depends on, ensuring that the pre-crisis elements stay alive. And so, let's say 7 years from now, nothing has happened, and there'll be no other pandemics of a similar nature. Will we still have this memory? And what do you think needs to be done to make sure that this, the system that you are putting in place remain alive?
It's that stage where you and your colleagues are trying to give each other a chance to respond. So thank you very much again for that question. When we reflected on COVID, our interpretation to date, just looking at what has happened, is that there are quite some similarities in terms of what a supply chain needs, regardless of what the issue would be or what the challenge would be. There are some main pillar elements that we think will apply across the board for the most part. And so you realize that when we started the presentation, we're talking about this aspect of recreation of frameworks and approaches and tools every time there's a crisis. And what we're trying to establish with this one specifically is having something that almost works for most scenarios. I think from our experience, what seems to be quite different with COVID this time is that countries had to rely on what they had, in country. Usually with the other crises or incidents that have happened, you may be able to bring in, say, experts from other countries. You may be able, your supply chain is not disrupted at the magnitude that we saw with COVID-19, when you can't have products fly in from different places. And so the question that we've been asking ourselves as a team, and even as we've been talking to others, is how much of what a country has can they use when you can't bring nobody else into the country, or when you can't bring other resources as we are used to when other disasters or other incidents have happened. So I would say that for us with COVID-19, that has been the main difference that we've seen, is that we are wanting countries to be able to, yes, draw from what may come from other places, but we're wanting a focus or recommending a focus on exactly what you can draw from what you have in the country. I don't know if my colleagues have something that they would like to add from what I've said.
Thank you very much for that very nice deep answer. And I also like the idea that you're going to collate experiences from others. I think this is really very much needed so that we don't rediscover the wheel, which is what your main message is, and how to create infrastructure that helps us keep going forward. So I really enjoyed your presentation. I hope you have a lot of success with your framework. We desperately need it. So thank you very much. And I will now move to the second talk. And this is about adapting public health, the supply chain supportive supervision. In order to, I guess, Mr. LMU, your concerns are about not just medicines needed for COVID, but other life-saving medicines as well. So with that, it's yours.
Okay, thank you. Thank you, moderator, for giving me the chance to share our experience in Ethiopia. So I do have a recording. So shall I share the recording?
I have it. We can share it from our end if you're.
Okay, thank you.
Mm-hmm.
This is Fallacy from USAID Global Supply Chain Program, Procurement and Supply Management Project in Ethiopia. I am presenting Adapting Public Health Supply Chain Support Supervision Program to the context of COVID-19 to maintain availability of life-saving medicines. So the presentation outline looks like we will have a brief introduction about what result-oriented support supervision is, its implementation modalities, major key activities that have been conducted to adapt to the context of COVID, and its results, and the summary of actions taken during the supervision program and its benefits, and we'll have finally the conclusion. As introduction, USAID's GHSCS-2021 project in Ethiopia supported multiple supply chain and health program initiative in a redundant manner. To alleviate this, GHSCS-2021 designed and initiated a comprehensive integrated support supervision program for Ethiopia health supply chain system that has been called result-oriented support supervision and abbreviated as ROSE. So this ROSE program integrates and streamlines the support, the different vertically provided support supervision activities into one modality. The supervision program addresses all building blocks of the supply chain system that include human resource, finance, logistic, information, service delivery, stock availability, and governance issues. It has a comprehensive tool that respond to the demands of key health programs that include HIV, malaria, family health, MNSH, and TB health program committee management at facility level. So as part of this, GHSCS-2021 adapted the program to the context of COVID-19 to reduce supply risks and support health facilities during the era of COVID-19. In general, ROSE is expected to bring continuous availability of health program quantities and reduce wastage at health facilities. It is designed to implement new initiatives, systems, and tools at facilities and improve the capacity of health facility staff and solve supply chain bottlenecks that lead to stockout and expiry. The supervision is normally conducted with government logistic officers working at supplying agencies, health bureaus and district health offices, so that we can maintain sustainability of the system. As part of this, GHSCS prioritize around 600 facilities to provide the supervision activity. So the implementation modality and timeline indicates that in FY20, we developed SOPs and tools for the supervision modality and selected 400 health facilities. In FY21 and last year, we provided the supervision at 600 facilities. We revised the supervision approach and disseminated the findings at different platforms and used survey CTOs. In FY22, we are advocating for ownership of the support supervision program, and we are building the capacity of regional health bureaus and district health offices. So at the end, our goal is site level support is owned and instituted at subnational level and provided continuously. During the era of COVID-19, we have conducted different activities to adapt, these roles to the context of COVID-19. We have been highly engaged in COVID-19 task forces that has been established at national and regional level, so that we have able to align our ROSE program to this strategies that has been designed to mitigate COVID-19. In addition, we have shifted the support supervision from paper-based to survey CTO program. That is a digital platform that helps to conduct the supervision using cell phones, tablets, and computers. We used communication technologies, emails, telephone calls, group chats, like Telegram channels, and team meetings, and the other. We worked to prioritize 600 health facilities for support supervision program. In Ethiopia, there are more than 4,500 facilities, where 1,200 of them are ART providing facilities. Among these, we prioritized 600 facilities. We engaged local stakeholders such as district logistic officers and the like. Finally, we adjusted the support supervision protocol. The first activity was abridging the site level checklist, so that the tool has been reduced significantly. We limited the number of people engaged during on-site supervision, and we provided PEP materials like face masks, gloves, sanitizers, implemented physical distancing or social distancing during the supervision program for supervisors as well as for mentees. We made facility staff individually rather than in teams at first instead of large groups, and we conducted discussions in large, well-ventilated rooms and sometimes in outdoor areas while providing feedback. We minimized contacts with unnecessary people and materials. So the next slide will show us the results that have been conducted in September 2020, January, and May 2021. The results of the availability of HIV/AIDS stressor co-medicines indicate that 99% of the visited facilities in the 3 rounds have TLD, where 86% of ART clients in Ethiopia are taking. So our support has a significant contribution for this. Availability for all ARVs, excluding TLD, was more than 97 throughout the period. The availability of HIV rapid test kits has shown progressive improvement, and availability for the 3 test kits was more than 97% in the fiscal year. Now, when you see the availability of family health and reproductive health stressor medicines, availability for all family health commodities was more than 93% following the supervision, except for emergency contraceptive pills and intra-contraceptive devices. Normally, IUCD's availability can be tied to demand constraints. In general, more than 99% of clients had access to at least 3 contraceptive methods of choice. This has a significant contribution for family health program. When we see the availability of neonatal child health communities, all communities except oral rehydration salt have adequate availability. Oxytocin was available in 97, 98, and 95% of the fast during the 3 quarter visits. And amoxicillin was also available in more than 84% of the facilities. So reason for stockout for some of these commodities is tied with non-full supply of these products. Normally, MNSH communities have a funding constraint, and the government is not able to fully avail these commodities. There is undersupply from supplying hubs, and there are also other reasons. And there are low demand and no request of this product by health facilities. When we see the availability of malaria tracer medicines, indicates that availability for at least one type of the malaria treatment, ACT options, indicates that 99% of the facilities have at least one form of ACT. So we can say that there was no treatment interruption in more than 99% of the facilities with respect to malaria treatment. At least one type of ALU was available in 99% of the facilities. ALU 6 or ST6x4 was available in 97% of the facilities that on the supervision conducted in March to May. Reason for stockouts or shortage related to malaria commodities indicate that there are shortages at IPSA hubs, there are undersupply, and there is also poor quality in reporting and requesting forms. Availability of TB tracer medicines indicates that availability of TB medicines and diagnosis is very good. TB patient kit was available in 99% of the visitor facilities, which is critical for TB health program, and our intervention on this area contributed a lot. When we see to supply chain performance of health facilities in different perspectives, the first one is storage condition. In general, 68% of the facilities achieved at least 80% compliance with storage standard requirements, like space adequacy, logical organization, appropriate storage temperature, security, storage conditions. On these parameters, 68% of the facilities fulfill these requirements. In general, steady improvement was observed in all storage management areas. When we see the inventory management practices, 91% of the facilities practice stock exchange during the context of COVID. Whenever there is shortage or excess, facilities were transferring stock from facility to alleviate shortage and stock out. 74% of the facilities conducted inventory at least annually or quarterly, and 86% of the facilities has experience of continuously removing expired and damaged products from their store. Improvement was also observed in all inventory management areas like physical counting, exchanging and transferring stock from facility, and separating expired product from one form to the other. When we see use of logistic management information systems and records and reporting forms, BIN card was used in 72% of the facilities, and 99% of the facilities has been using the report and request form to request health communities from supplying hubs, and 83% of the facilities used the latest or the recently updated reporting and requesting form. In general, the IPSA or the no report, no product policy contributed for high percentage of use of reporting and requesting form. When we see use of reporting and requesting form by different programs or by disaggregation by different program, it indicates that RRF was used for all program commodities, even for recently integrated products like MNSH and HIV rapid test kits. RRF was used least for RTKs and viral load commodities, while it was used in more than 95% of the facilities for ARV, TB, family planning, and maternal commodities. Improvement was also observed from time to time because of our intervention. So the facilities, the requisition of health program committees using the reported requisition forms. When we see the quality of the reporting and requesting form with respect to timeliness, completeness, and accuracy, there is also significant improvement in timeliness, completeness, and accuracy of RRF reports by 5% and 3%. And the overall data quality of RRF is around 84%. In general, or in summary, the major actions that has been taken during the site level support include, like we have been providing on-site orientation on new initiatives such as tele-transition and multi-meals dispensing implementation activities, especially that has been promoted during COVID-19 pandemic. We have been providing on-job training on completion and timely submission of the report and requisition form for supplying caps, which are critical for resupplying health program communities from higher level to facilities. We supported facilities to place emergency orders in cases where they are in shortage, and conducted stock transfers with nearby facilities. This contributed for alleviating stockouts and shortage at facilities. We have been regularly communicating the 70 supplying branches throughout the country so that they can execute timely resupply for health facilities. We have been strengthening the internal inventory and stock management practice at health facilities so that their system will be smooth and avoid stockout and shortage. We have been distributing recently or updated hard copy versions of RRF or reporting requisition forms and IFRR formats. We have been also advising health facilities to organize and clean their store, conduct dejunking, and update their inventory management tools. We have been conducting thorough discussions with health facility management to improve commitment of health facilities professionals, to combat the COVID-19. We have been also discussing with district health office and health facility logistic officers to alleviate shortage and other activities. In addition, we have been providing written as well as verbal feedbacks so that, and we developed plan of action to alleviate the major challenge that has been observed during the supervision. In general, adapting the roles to the context of COVID-19 helped or provided a number of benefits. The first one is it enabled to motivate health facility staff so that to maintain health supply chain activity during that difficult time. We were successful in motivating facility staff so that they were able to execute different supply chain activities at their facilities. We have been it enabled continuous communication and monitoring with health facility staff to boost their confidence and morale. We were able to, build the technical capacity of facilities that have, that has been limitation. We are able to identify weaknesses and, bottlenecks, and we were able to, it enabled to solve those problems. It helped to improve availability and access to medicines and solved different supply chain bottlenecks, especially shortages and expiry. And in general, the supply chain performance at facilities were improved significantly. In conclusion, The supervision contributed to implementing a resilient system that can withstand shock, especially like shocks like COVID-19. It improved stock visibility, availability, human capacity, operational efficiency, and stock redistribution and resupply, so that to prevent shortage and expiry. Adapting technical support programs like support supervisions to the context of COVID-19 pandemic required flexibility, creativity, and use of new and old technologies. So we were able to do all this, and lesson learned from ROSE implementation during COVID-19 can be quickly adapted, can be applied during future crises, including natural disasters and public health emergencies, especially here in Ethiopia. We are also currently further adapting the ROSE program, to adapt the current security challenge in the country. Thank you. I have finished the presentation. If you have any question, you are welcome. Thank you.
Thank you very much. We have a few minutes. Anyone else has some questions? Okay, let me ask you a quick question then. What is, it seems like most of your metrics improved. So do you see this as something that you want to do on a permanent basis, or do you see this as something that's, in other words, what is it that you've learned from this experience that you would probably institute on a permanent basis?
Okay, thank you. I think we have learned a lot from this experience. If I get your question, crises like COVID-19 will disrupt the supply chain and normal program implementation. Therefore, implementers should be ready to be flexible, creative, and adapt or to regularly adapt their implementation approach, modality, and tools for any crisis like for any crisis like COVID pandemic or any other security issue. So this is what I can say if I get your question.
I'm muted. Yeah, that's correct. Yeah. So you're right in the sense that I think one of the things that's interesting about this pandemic is, we are learning that we are more, in some sense, more adaptive than we thought we were, and we can make changes more than we thought we could. And some of you have experimented with a lot of changes, and it seems to have, if I'm looking at your metrics, unless there's a drop in demand, it seems like you've done very well with respect to availability. Right? And so I think that's the point.
Yes, of course. Yes, of course. We have a large team, and we have been highly engaged in the COVID-19 task forces, so that we were, catchy to adapt our programs, in the different regulations and different protocols that has been promoted by the government as well as by WHO, in addition to by USAID as well as by our project. Therefore, medicines are critical, especially at that time. ARVs, TB commodities were critical to be available at health facilities, so that client should get those products from facilities. Therefore, what we have been doing is that we have made a great attachment with supplying hubs, that is called Ethiopian Pharmaceutical Supply Agency, and with the Ministry of Health that have been, and regional health bureaus that have established different technical working groups or task forces at that time, so that we have been distributing health commodities to health facilities, like 6 months commodity has been distributed to health facilities, so that health facility can provide clients like a from 3 to 6 months supplies. In cases of shortage, facilities where we have been providing support facilities to redistribute commodities from their nearby facilities, even from one hub to the other hub. So our interventions really provided provided a good support to the government to avail those commodities to the facilities, so that facilities were able to serve their clients, especially those facilities that are under critical follow-up by the project, around 600, were highly monitored. We have been making a regular meeting at the project with regional staffs. We have around 30, 40 regional staffs. So we have been making regular meetings, like bi-weekly team meetings, to evaluate any challenge and stock problems and avert challenges. That's why we have been making a good progress, especially in the indicators like special availability with respect to HIV commodities and LMICs, especially reporting and requisition forms that are critical, for the hub to resupply facilities. That is what I can say.
Thank you so much for that. And our next speaker, who's going to be talking about, let me just look at my notes, about governance and workforce related challenges. She's a physician in Zambia, Dr. Leah Sapulanda. I think she's having some technical issues connecting. And so we have, so do you know is she having issues connecting, or she's?
Yeah, she has been unable to join the Zoom so far.
Okay.
And her presentation is would be a live presentation, so we would have to wait a few minutes. Until then, if anyone has extra questions, would you mind taking those?
Yeah, and so I was thinking that, we have maybe a couple of minutes. We'll give the doctor a few minutes. And I think this is an interesting forum to discuss some of the lessons that you've learned and some of the experiences. I want to pick up on both the talks today. Village Reach started off with the idea of kind of learning in some systematic way, and then we've seen from Ethiopia some of the excellent outcomes that they have. So maybe it's a fertile area. So Sammy, you had your hand up, I think. Yeah. Does anyone?
Thank you very much. Normally, especially to kind of what you have done, it's about kind of adapting your support to maintain the service level target that you are expected to maintain. To be honest, COVID-19, as we all know, is very special. Normally, it has its own impact or effect in terms of demand and supply as well. As you know, it has its own implication in terms of compromising the health-seeking behavior of the the clients that need their medicines continuously, and at the same time also the country's health service system needs to be responsive enough to maintain the service level, as I said earlier. So there were some kind of programmatic changes in terms of maintaining, like the multi-month dispensary and other interventions that were implemented programmatically. So when you come to the implementation support part of your intervention, you need your program or your intervention should be more responsive, because, for example, when you talk about the multi-month dispensary, you're talking about pushing more stocks to the lower level facilities. So you need to be adaptive to kind of maintain that level of service. So you need to be robust enough to maintain that support. So maintaining this service level in that context means you are more adaptive, you are more flexible and adaptive in terms of your support as well. So I think this has to be praised, because in that context, in Ethiopia, we're able to maintain those service level targets, including operational as well as from the demand perspective, availability level target. So I think we have to also kind of see it in this perspective as well. Thank you very much.
Thank you. Excellent point. While we're still waiting for the doctor, I want to ask, many of you have, good, excellent field experience here. And so one of the things that intrigues me is, in general, we've struggled with being adaptive and making rapid changes. But now in COVID, we've seen, a lot of changes and a lot of adaptation. So do you think that this is going to sustain and that we have discovered that we are more adaptive and we are able to make changes faster than we thought we could? Or do you think as the pandemic wanes, we are going to go back to our old ways? I think it's a question for all of you. Maybe I should ask somebody from the Village Reach program to respond to that, because they are interested in, understanding what went wrong and how to make things go better in the future. So the question is, what have you learned as organizations rather than as systems?
Maybe shall I reflect a few points? Maybe.
Yes, please go ahead.
I think, as you have said, we need to learn. We need to learn from existing, challenge, and make the future, act in responsive way to avoid such issues. Therefore, this was a big risk. This was a big unidentified risks that disrupted the supply chain practice. Therefore, and caused a lot of problem in countries, especially in our country, and especially importing products from abroad was highly affected. And as a result, shortage were in some products, especially shortage were there. And services were interrupted. Therefore, I can say that organizations should learn from this pandemic, and this such types of risk should be anticipated in the future, and future practices should continue anticipating such risks and continue adapting the existing practice. I do say like that, instead of returning back, it will be better if supply chain experts always anticipate risks, assume such huge risks may happen anytime, and prepare for the worst and serve their community. So this is my opinion.
Thank you so much. I think our next presenter is in the room. Could you please, I believe you are here. Please, doctor, are you here in this room right now? Not I don't see the doctor in the room, so
Yeah, perhaps she joined under another name, but
she may have joined as the HP guest, and I see that she's muted. Are you able to ask her to unmute, Sonu?
Yeah, I have not heard anything.
Okay. That's all I can do. She did say that she made it in.
Hello? She's
Doctor, is
unmuted.
that you?
Hello? Is it? Doesn't seem like she's either here or she's able to connect. So we only have 10 minutes in any case. So I think, oh yes, we cannot hear you. You have to unmute yourself. Is there any way we can unmute her? Sonu?
Yep, I just sent her a request.
Okay, she's unmuted.
Doctor, can you try talking? We cannot hear you. I don't think her audio is connecting to Zoom.
Yeah, I think her audio is not connected. Well,
Doctor, we cannot see your screen either.
so we are running out of time in any case. We only have 10 minutes left in the, given the technical challenges, perhaps.
I could just offer, this is Sue.
Yeah, go ahead.
I could just offer that if she were able to pre-record the video or record, a soundtrack to her video presentation, I could add that to the recording of this track that will be posted on YouTube. So people would still be able to see it after the fact.
Excellent. Thank you so much. So yeah, I think that's probably the best given the fact that we only have under 9 minutes and that presentation probably will take around 20 minutes. So again, thank you all for participating in this very important track, and we will post, as Sue pointed out, all of this is going to be posted on YouTube. And I'm really excited about the work that was presented, and I really hope the Village Reach has success with its project, and Mr. Alamu's work, wonderful work in Ethiopia continues to occur. Thank you, everyone, and hope to see you again soon. Take care.
Thank you, everyone.
Thank you, everyone.